Good morning. Besides travel expense reimbursement, I don't have any conflict of interest to declare. In 2019, deep sedation is still needed in many patients in the ICU, such as severe respiratory conditions, uncontrolled brain disease, such as seizure or traumatic brain injury, therapeutic hypothermia, major surgery or intervention, and sometimes agitation. For this, we need rapid, safe, and reliable tools to perform safe deep sedation. Besides these cases, there is no indication for deep sedation, and most of our patients shouldn't be sedated at all or should be lightly sedated. It's possible even after major surgery, as shown by Dr. Schank in a randomized clinical trial, where he showed that immediate interruption of sedation is feasible and is associated with a shorter time to extubation after major surgery in critically ill patients. For this, we also need rapid, safe, and reliable tools to provide rapid and safe awakening of these patients. But we all know that sometimes with our population or very sick patients, sometimes old patients, sometimes obese patients with kidney and or liver dysfunction, it's sometimes very difficult to provide deep sedation and rapid awakening without having difficulties. This is a patient in my unit. We also do burn patients, and you can see here a young gentleman addicted to alcohol, severely burned with his both hands engulfed into his abdomen. And of course, it was not possible to wake him up directly after surgery, and we needed deep sedation in this patient. So we all want to avoid bumpy takeoffs and bumpy landing, deep sedation and rapid awakening. We all know from observational studies, rather than randomized clinical trial, that over-sedated patients and under-sedated patients are widely and often seen in the critically ill setting. For instance, in a German study published a few years ago, most of the patients were over-sedated with the Ramsay score above the targeted Ramsay. And this occurred mostly in the very beginning of the ICU stay. A few patients were categorized as under-sedated, and mostly after a few days of the ICU stay. It has been shown in observational studies that deep sedation in black bars are often seen in the very beginning of the ICU stay and is associated with prognosis, a longer time to extubation, and with outcome with a higher risk of dying even 180 days after the ICU stay, and both in univariate analysis and after adjustment in multivariate analysis. Under-sedation is also seen in some of our patients, and in these observational studies performed in the US, 20 to 30% of the ICU population were categorized as under-sedated patients. Facing agitation and under-sedated patients, the first step is to assess pain with dedicated tools and dedicated drugs, and then the second step is to look for delirium. Delirium is also very frequently seen in the ICU. About 40 to 60% of our critically ill patients will experience delirium during the ICU stay, and it's also associated with prognosis with a higher risk of mortality in patients with delirium. 10%, sometimes more, depending on the studies, 10% of these patients will have hyperactive delirium, meaning agitation, and sometimes they are severely agitated and can be at risk for themselves and for the caregivers. And for this, of course, we need a specific diagnosis. Sometimes there is a specific diagnosis to be made, and specific treatment, and sometimes symptomatic treatment. Maybe antipsychotics, I'm not so sure anymore. Maybe dexmedetomidine. Sometimes we don't have any choice but to restart sedation, and sometimes deep sedation, because sometimes nothing really works. And it has been shown that physiotherapy and early mobilization are good ways to prevent many cases of delirium. Under sedation can be a cause of agitation, And in the ICU, we mostly use midazolam or propofol to reach, to attain the targets of sedation. But as presented by the last speaker, we know that midazolam, as well as propofol, when we use extended infusion, do accumulate and will accumulate even more in some populations, like the obese patients, the kidney or liver failure patients. On the other hand, inhaled sedation, isoflurane or sevoflurane, do have pharmacokinetics properties that may be of interest in some difficult to sedate patients, such as a rapid onset and offset of action, no significant signs of tolerance, tachyphylaxis, or wrist buckle syndrome. Something very interesting for us is a drug clearance via pulmonary exhalation, and very few impacts of renal or liver failure on its pharmacokinetics property. However, it has a dose-dependent hypotension effect. It can raise the intracranial pressure by cerebral vasodilatation. There is a very small risk of a very severe side effect, which is malignant hyperthermia in predisposed patients, and no really risk, apparently, in the literature of nephrotoxicity, even if serum fluoride levels can be elevated after a few days of administration. What are the studies out there? Mostly it's short-term inhalation sedation in the ICU, less than 12 hours in several single centers clinical trials where the investigators compared inhaled sedation to IV sedation, mostly in cardiac surgery patients. And they all showed that it was both feasible and associated with a shorter time to extubation. Sometimes, let's be honest, it's in minutes or a few hours. So it might be of interest, but maybe not in every patient. Concerning the prolonged administration studies, there are a few studies as well. One 15 years ago by Peter Sake. So it was 52 hours in median, so 2 to 3 days of administration compared with midazolam. And so the authors showed that it was feasible and associated with a shorter time to extubation. In Montpellier, we did a small randomized single-center clinical trial, including 60 patients, and it was, and like the previous author presented, it was also associated with a shorter time to extubation and a shorter time to wake up compared to IV drugs. And cardiac arrest also, as she presented very nicely, a shorter time of ventilation and a shorter time of ICU stay. In pediatrics, there is a feasibility study in a population very specific, the difficult to sedate children. They were defined in this single-center retrospective study as out of the target despite maximal dose of IV sedation, or the target of sedation reached but with unusual high dose of IV sedation, or people difficult to wean, so a difficult and bumpy landing. So at this time, the authors, they switch from IV drugs to inhaled sedation, the sevoflurane in this case, and they showed that they could decrease dramatically the quantities of IV drugs that were administered, and they were concerned about the pain management, so they increased the quantity and the level, the quantity of morphine. There are other studies ongoing, one in Europe and one in North America, that will help us assessing the results of long-term sedation with this inhaled sedation. So my conclusion would be that over and under sedated patients are frequent in the ICU. Of course, no or light sedation should be targeted in most of the patients, but there are still indications for deep sedation. However, in our population of critically ill patients, all IV sedation drugs will and do accumulate because of pharmacokinetic specificities in critically ill patients. And Whether inhaled sedation may be included in the toolbox for long-term and difficult to sedate cases remain to be investigated. Thank you.